Hello and welcome. This is your brain on drugs, and this is the punk rock psychiatrist. Well, today we're going to be talking about SNRIs, and depending on how long this goes, this may be one episode or two. So we'll kind of see how we go with that. But let's go ahead and get started with the SNRIs. So, we talked about the SSRIs in the last couple episodes, and I think those are probably the most common antidepressants that are used. And then next most common would be bupropion, Wellbutrin, and then the SNRIs. So remember when I gave that list of the medications and what their rank was in the top 300 prescribed medications in the United States, and we had all the SSRIs except Luvox that were in the top 100, and bupropion was, I think, number 22. Well, when we look at the SNRIs, we've got duloxetine at 31, and venlafaxine at 44, and desvenlafaxine at 208. And levomilnacipran does not make the list, which is no surprise to me. All right, and the fact that desvenlafaxine is that far down doesn't surprise me either, but essentially, the two most commonly used SNRIs, duloxetine and venlafaxine, are less popular than all the SSRIs except paroxetine um, and paroxetine and fluvoxamine. And I probably use duloxetine more commonly than some of the SSRIs personally, and we'll get into a little bit why that may be. So let's start off with the list. I've already mentioned them, but let's go through them. So these are the serotonin norepinephrine reuptake inhibitors. That's what SNRIs are. And we've got venlafaxine, otherwise known as Effexor, and there is Effexor XR, and then there's venlafaxine ER, which is the generic version of Effexor XR. And then you've got duloxetine, which is Cymbalta, and there's another branded product called Drizalma, which is a sprinkle product that you don't have to swallow. And then we've got desvenlafaxine, which is the metabolite of venlafaxine. If you remember back when I explained that des means desmethylated, demethylated, which is a typical prefix when we have a metabolite of a medication. Descipramine, I think, was the example at the time that I was talking about that. Well, desvenlafaxine is another one. It's the metabolite of venlafaxine, and its brand name is Pristique. And then we have milnacipran Savella, which is actually not an antidepressant, but is an SNRI. And then we have levomilnacipran, otherwise known as Fetzima. And, you might be a little confused because remember when we talked about citalopram and S-citalopram, and I said that, I explained what enantiomers were and that, when molecules are a certain configuration, they can either be looked at as right or left. And right is, the Latin word for right is rectus, or R, and left is sinister or S, and that's why we use R and S. Well, there's actually 3 different methods for determining. It's really arbitrary, right? Which one we decide is right or left, but science has to come up with a way of doing it. And the first way is when we use R and S, and that's looking at the geometry, and it has to do with what group, which group is larger on a specific part coming off of the carbon atom. So that's how they basically just made up a rule, and this is how we're going to determine which one is right and left, and we'll call it an RNS. But then there was another method where they shine like an optical light through it, and it spins, and does it spin left or does it spin right? And we use plus or minus for that. Used to use little d little l, but it got confused with the third method where we use big D big L, which stands for dextro and levo, hence levomilnacipran. And that has to do, I won't go into a lot of detail, but it has to do with its relation to the molecule glyceraldehyde, and, is it more closely looks like the right hand or the left hand enantiomer of glyceraldehyde, and then it gets tagged with the same right or left based on that. And The other thing you may be wondering is, why do we say, rectus or uh, rectus or sinister versus dextro or levo? And they both, all these terms come from Latin, and there's actually three words for right and left in Latin, and two of them are rectus or dextro for right and levo or sinister for left. And there's actually a third one, but we don't use that in the configurations of molecules. But that's why sometimes you'll hear levo, because they've used a different method to determine if it was right or left. And sometimes you'll hear S. So I just wanted to kind of explain that levo it would be just similar to saying S milnacipran, but used a different method. So we have to use the word that we've determined that's the one that we use for that. So let's start off and kind of talk about what is an SNRI, like what's its mechanism of action, how does it work? And, we've already talked about this, I think, quite a lot. And, we just talked about the SSRIs, which and we talked about how they're not really selectively serotonin reuptake inhibitors, but they do predominantly uh, block the reuptake of serotonin into the releasing neuron so that there's more serotonin in this presynaptic cleft to interact with postsynaptic as well as presynaptic receptors to cause the effects that we wanted to cause. And the only difference here is these do that, and they do the exact same thing with norepinephrine. All right. So we've already talked about this because the TCAs affect norepinephrine, right? So we already really know. In the podcast, we've already talked about what SRI does and what NRIs do. So I don't need to go into depth. Please listen to past episodes if you want that depth. But the important thing to know about these is that they are blocking the reuptake of serotonin and norepinephrine. And when we talked about the SSRIs, I mentioned that most of the SSRIs aren't really selective. They do other things. Some are anticholinergic, some have some DRI, some have some NRI, some have some alpha, some sigma, some, various other things that they do. The SNRIs are a lot more selective for serotonin and norepinephrine, though they do have a little bit of dopamine, and venlafaxine is the one that would affect dopamine the most. Often blocking, when you block the norepinephrine reuptake pump, and remember the serotonin reuptake pump is abbreviated SERT, SERT, while the norepinephrine reuptake pump is NET, and the dopamine reuptake pump is DAT, DAT. So that's because norepinephrine is NE, dopamine's DA, and serotonin's SCR, I guess. And then T means transporter, so transporter pump. But yeah, when you block NET, you also tend to block some reuptake of dopamine as well in the prefrontal cortex. And I'm most aware of that when it comes to venlafaxine. But you're not really all those other receptors we talked about. I think we talked about 5-HT2C and the muscarinic receptors and even the nitric oxide synthase receptors. None of those are affected by the SNRIs. It's S, N, and maybe a little bit of D. And one interesting thing about venlafaxine, and a lot of people don't know this, particularly non-psychiatrists, and it's really important. And I see this error happen quite frequently. Okay. And I'm going to talk about this in a second with all the meds, but I want to just talk about venlafaxine now. The degree to which they affect serotonin and norepinephrine differs. So that's one of the main differences between the different SNRIs is the ratio of how much serotonin effect they have to norepinephrine effect, and they all have a different ratio. With venlafaxine, at doses below and maybe even at 150 milligrams, you're primarily like it's basically just an SSRI. You're not really getting any norepinephrine at all. You've got to go above those 150 milligram dose before you start affecting norepinephrine. Now, if any of you out there know the max dose of venlafaxine, for the XR formulation, it's 225. For the IR formulation, it's 300. However, we can go higher. I've heard as high as 600, if that sounds crazy. I've never gone over 300. I think 300 of XR is the highest I've ever gone, even though 225 is the max. 300 is the highest I've ever gone. But less than 150 is an SSRI. More than 150, we've got SNRI, and more than 375 milligrams, we start having triple effect. That's when we start affecting dopamine reuptake as well, if the patient can tolerate such a high dose. And there are a handful of them out there, and there may be ones that you need to consider that for. But just kind of the interesting thing about venlafaxine is how it blocks the reuptake by the dose. And the mistake that I mentioned that I see is that I see a lot of patients that are on like 75, maybe 100, or something like 112.5 dose, and maybe even up to 150. And I don't see a big point in that, because we're giving you the SNRI because we want to give you the N. We want the norepinephrine effect. That's why we've chosen an. If we were just going to want serotonin, why not just go with an SSRI? And so what a lot of, folks I see, they're on basically the SSRI dose of venlafaxine. And then you get a lot of the downsides of venlafaxine, and we'll talk about those later, but you get a lot of those downsides, but you're basically, giving the same effect as you would with an S-citalopram. And so, you've already tried presumably, typically when we use an SNRI, the person's already taken an SSRI, maybe one or two different ones, and it's had a problem with it, didn't work. And so we switched them to an SNRI. And if we're giving them low doses of venlafaxine, then we're just giving them a third SSRI. And, why do that, right? Let's actually get them onto an SNRI dose if we're going to give them an SNRI. And we don't have this issue with any of the other SNRIs. It's only venlafaxine, because venlafaxine is the least norepinephrine reuptake of all of the SNRIs. It's also not my favorite antidepressant. In fact, one of my least favorite. And we'll go into that when I talk about my disadvantages. So, as I said, with duloxetine, you're getting both SRI and NRI activity at pretty much all doses. And then with levomilnacipran and milnacipran, you're actually getting more NRI. So I would say venlafaxine leans more towards SSRI territory. Duloxetine, desvenlafaxine are more evenly balanced, and then levomilnacipran, milnacipran are more towards the norepinephrine. So I think when you're thinking about like their effects, or what effects we're trying to get with the patient, or we're thinking about, the side effects that we're trying to avoid, when you're going to pick which one you want, you can kind of think, do I want more serotonin? Do I want more norepinephrine? Do I want more balance? I typically go with the balance. That's why I usually pick duloxetine. But, it's going to depend on the patient. And so, as I mentioned, there are there are ratios. So what are those ratios? So venlafaxine Effexor is a 30-to-1 as far as its potency for the serotonin reuptake versus the norepinephrine reuptake. So 30-to-1. That's why you do need you need to be over 150 milligrams. So that's, over 150 milligrams, the next dose is pretty much 225. So it's pretty much the max dose of Effexor that you need to be on before you're even getting the SNRI from it. And that's, for me, one reason not to use it. If I have to get them all the way up to the max dose, maybe I don't want them on the highest dose. Maybe I don't want, they're going to have more side effects. They're going to have more issues. It's going to be more withdrawal trying to get them off. So, that's something to consider when you're thinking about that. But I think, it was the first SNRI, right? So venlafaxine was the first SNRI. So it's the one that's kind of we have the most data on. there's been more chance for people to have been taking it because it's been around longer. People are more from, people learned it in, people that were in school 10, 20, 30 years ago, they all learned about it. And so that may be why it's used so much. And also, it went off patent and became generic first of all the SNRIs. Now, we've got desvenlafaxine and duloxetine also generic, so that they've come down in price. And so, but I think the fact that, venlafaxine went generic sooner, and you're wanting to give someone an SNRI, and, you're trying to get it covered by the insurance companies. These are, I think, some of the non-clinical reasons why you might be seeing so much venlafaxine, and maybe we should be seeing less of it. Okay. So this 30-to-1 ratio, it's not great for me. And then when we look at desvenlafaxine, Pristiq, it's 10-to-1. And as you'll remember, desvenlafaxine is the metabolite of venlafaxine. So desvenlafaxine as the metabolite, not only does it have more norepinephrine reuptake, it also has a longer half-life. And so it has less withdrawal as well. So that might be a benefit to that one. And then duloxetine, and you may be thinking, how is that possible? If it's just the metabolite, then why isn't it the same? Well, this is something interesting in medicine. Um, Sometimes the metabolite is the active compound, right? You've got an active metabolite. Sometimes the metabolite is not active, right? Most meds are metabolized by the liver into something else. Sometimes what they're metabolized into has effect, but different effects. Sometimes the effect of the metabolite is greater than the parent compound, and sometimes it's less, and sometimes it's no effect. And that can go the other way as well. Sometimes the parent compound is not effective at all. It's the metabolite's the only active compound. Sometimes the parent compound is more effective, and sometimes equally effective. And so it depends on each medication that we're dealing with. In the case of this one, both venlafaxine and desvenlafaxine are active. And so that's why, venlafaxine would be a mix of both, whereas desvenlafaxine is just the metabolite. Therefore, they have different ratios. All right. So next one, duloxetine, Cymbalta, also is a 10-to-1 serotonin to norepinephrine. And then milnacipran is actually a 1-to-1. So it's one-to-one ratio. And then levomilnacipran is actually a 1-to-2. So more effect as norepinephrine than serotonin. So, I mean, when you think about Effexor being 30 times stronger serotonin than norepinephrine, that would mean that levomilnacipran is 60 times more norepinephrine than serotonin than venlafaxine is. And so, and that's where you could have some different in effect. All right. That's where you're going to find your differences. The main differences between the SNRIs, with the SSRIs, there was more about, did they affect other receptors, and, drug-drug interactions were quite different, and half-lives were quite different. With these meds, their half-lives are all very similar. Venlafaxine is a bit shorter, and levomilnacipran a bit shorter, but they all have relatively short half-lives. Even when I discussed fluvoxamine and paroxetine and said that they had short half-lives, I believe paroxetine's 24 hours and Luvox is 15 or so. These are all less than 12, all right? Between 5 to 12 hours. So the half-lives of the SNRIs are all about the same and less than the SSRIs. They all, and all of them don't really affect the P450 system all that much. A little bit, but there's not the massive effects as you see with the SSRIs. And then, so the main difference between them is this ratio of SSRI to NRI. So that's the main stomping point that I want to make with these when we're differentiating them. There are some other subtle differences, but this really is the big difference between the SNRIs. So, let's just, go over what the FDA indications are. I had that chart. We had an episode on that, but let's just review what the FDA indications are for the SNRIs real quick. Venlafaxine, it's FDA approved for depression, generalized anxiety disorder, social anxiety disorder, and panic disorder. Desvenlafaxine, depression. Duloxetine, depression, generalized anxiety disorder, diabetic peripheral neuropathy, fibromyalgia, chronic musculoskeletal pain. Levomilnacipran, just depression, and milnacipran, just pain, I believe fibromyalgia. Milnacipran has no FDA approved mental health indications in the United States. Of course, the FDA is only in the United States, but it actually is approved for depression in other countries. So, you know, if you've got a patient with fibromyalgia and you'd like to give them milnacipran, you don't really, I would not be adding another antidepressant. I would see how the milnacipran does, because it is very similar to, these other medications. It's very similar to levomilnacipran, and that's approved as an antidepressant. And also, I wouldn't want to give them, another SSRI or SNRI with this SNRI. So if you are using this, I would if I were going to use, first I would assume that it would have antidepressant function. I would see how it went with that. And if it didn't, I would add something like maybe a mirtazapine or maybe a bupropion or something like that. I don't know. I would try and, even bupropion has got the norepinephrine function. I'd try to do something where I'm not overlapping what the drugs are doing too much. All right. And I think, mirtazapine is probably maybe one you could add to these, but there's not much. Maybe a gepirone or buspirone, although I don't really think they're all that effective. I'd try to think about something else. You could, yeah. I'd try to think about, let's not do more SRI or NRI activity if we already have one on board. And even though milnacipran's not an antidepressant, it's an SNRI, so I don't want to double up on those. So adverse effects. Wow. When we did the SSRIs, I had like 6 or 7 episodes on adverse effects. And the good news is, because these are SNRIs, we don't have to talk about any of those serotonergic effects again. All the adverse effects that you can have with SSRIs, you can have all of those effects with these, because they block the reuptake of serotonin. So, all that stuff I've already talked about, it applies. And what's cool is I'm only going to talk for like a minute on the additional effects, because there aren't that many. There's not this huge list of adverse effects associated with the norepinephrine reuptake as there is with the serotonin. So, serotonin, you got the GI, the big ones, the GI effects, insomnia, or somnolence, sexual dysfunction, suicidal thoughts. Those are some of the big ones. Emotional dulling. Listen to those episodes if you haven't already. If you want to know about the adverse effects of serotonin, you're going to find all that with the SNRIs. And then the noradrenergic effects are mostly cardiovascular type effects. So when we think about norepinephrine, right, this is the fight or flight. When people think about the fight or flight, and they think about their adrenal glands, that's epinephrine, norepinephrine. Norepinephrine is a metabolite of epinephrine. It crosses the blood-brain barrier. Epinephrine does not, as far as I'm aware, and they have very similar effects on the body. In the actual brain, some of the effects that we want it to have are maybe some more energizing, helping with concentration, helping with energy, those type of effects. But then there's effects on the peripheral system, so that's the system outside the central nervous system, that we don't want it to have. And those are where our additional adverse effects are going to be happening. It's those kind of norepinephrine effects on the peripheral system of the body. And that would be things like dizziness, increased blood pressure, increased heart rate, sweating. So, think about when you go into that fight or flight, panic kind of state, those are the effects that you might get with the addition of the NRI that you get with the SNRIs. All right. It's that, just that, increased adrenaline type of sensations, sweating, dizzy, increased heart rate, the things that are going to get you away from the bear. Right. But of course, when there's not a bear to run from, we don't want these effects. And so, but these are things that could happen, but yeah, they're fairly well tolerated. I don't get a whole lot of issues on this with patients. They're able to tolerate the meds fairly well, but if they don't, this is the additional things that they might experience that they wouldn't have gotten with the SSRIs. And then, dry mouth. I mean, we mentioned that with the SSRIs. I'm not sure, I postulated that maybe there's some anticholinergic effects on the SSRIs. There's pretty much no anticholinergic effect with the SNRIs, but the dry mouth, that's still something that could occur. And then with duloxetine in particular, there was a warning that the FDA made the manufacturer put back in 2005 of risk of hepatitis and cholestatic jaundice. And so those are some liver issues. And so, I generally don't check labs with these antidepressants. I mentioned, potentially checking a sodium with the serotonergic medications on, patients with symptoms. You might want to check liver function with duloxetine. This is the one where we might have some risk there. I've given duloxetine to 100 patients or more, and I've never had a patient have any kind of impaired liver function. Now, that is to say, that's not necessarily going to continue forever. And if I have a patient that already has liver dysfunction, I'm not going to choose duloxetine. All right. That's the one antidepressant that I'm really not going to give somebody if they've already, if they've already got liver impairment, maybe from alcohol abuse or hepatitis of some sort. Don't give them duloxetine because it can actually cause that. Very rarely, but it happens. And so, of course, if they already have it, we're not going to want to increase that chance even more. And then with levomilnacipran, I I don't have any experience with this medication. Giving it, seeing a patient on it, nothing. But additional adverse effects that I have in my list for this medication are mydriasis, which is increased size of your pupils. I'm not sure that that would cause any problem for anyone. I mean, maybe it would make you um, more sensitive to sunlight. And then urinary retention and seizures, I also have as additional risks with levomirazepam. Not sure how big of a risk those three are, but or why they are specifically listed for levomirazepam, but that is a difference that I have. So, I mentioned drug interactions, and we spent quite a bit of time on drug reaction interactions when we talked about the SSRIs because there's a lot of CYP450 inhibitions, particularly with fluvoxamine, fluoxetine, and paroxetine. And a little bit with sertraline, it's got some moderate 2D6 inhibition. The rest of them pretty minimal, but there's a lot less to be worried about with the SNRIs. All right. So, what are some of the drug interactions? Well, remember, we would talk about the MAOIs and how we don't want to use them within 2 weeks of other serotonergic medications. And we talked about that with the SSRIs, and these are also SRIs. So, that same warning with the MAOIs applies to the SNRIs. So, we don't start them within 2 weeks, and we don't start MAOIs within 2 weeks of the SNRIs. So, and remember, this is because we're worried about serotonin syndrome. I had an episode on that. All right. And then neuroleptic malignant syndrome, talked briefly about this, that, dopamine can be affected with these medications. It's very rare, but it's something that you need to know is possible, so that if you're seeing the signs of it and they're not on a dopamine blocking medication, that you don't rule it out. And actually, SNRIs are a little bit, there's more reports of SNRIs and SSRIs in causing neuroleptic malignant syndrome. And the drug interaction is if you're combining them with other medications like antipsychotics and dopamine antagonists that cause it. I would not not do that. If they were taking an antipsychotic dopamine blocker, I would not be like, oh, I'm not going to give them SNRI because I'm worried about NMS. Um, I would, if it happened, I might think, oh, well, maybe it was the addition of the venlafaxine that caused that, and we need to be careful now. But it's just something to keep in mind, not something that you would not do it. All right. So then let's talk about each of the medications. So venlafaxine, it actually has no significant inhibition of P450 enzymes. It's one of the very few antidepressants that has not even mild. So like even escitalopram had mild, which I don't consider mild to be an issue at all, but venlafaxine doesn't have any inhibition of any P450 enzymes. So that's good. Um, However, it is metabolized by CYP2D6 and 3A4. And so if you combine it with an inhibitor of 2D6 or 3A4, they could increase the levels of venlafaxine, which could increase your risk of cardiotoxicity. Because remember that NRI, it gives us those cardiovascular effects. And if we have too much of those effects because we've increased the levels, you have an increased risk of cardiotoxicity. All right. So while it doesn't inhibit enzymes that would affect other meds, it is metabolized by those enzymes and could be affected by other meds. Now, desvenlafaxine, and and this is something that's always good to know, metabolites don't get metabolized again, typically, but especially by the liver, the P450 system. So desvenlafaxine is created if you take venlafaxine, 2D6 3A4, turn it into desvenlafaxine. But if you just take desvenlafaxine, you're not worried about this at all. So it actually has mild inhibition of 2D6 itself, but it's not affected by that. So if you're taking a 2D6 inhibitor, desvenlafaxine isn't affected by any of the enzymes because it's already the metabolite. It's renally cleared. Um, and another thing to note is that meds that are renally cleared and not metabolized by the liver are meds that I worry about more when someone has renal issues. So if you've got a med like gabapentin or desvenlafaxine that are renally cleared, you have to worry more about how the kidneys are affecting them. Generally, what the liver is doing is it's metabolizing something and making it safe for the kidneys. If you're not getting metabolized, you then are a little bit higher risk to the kidneys. All right, and we'll go through all this kidney and liver risk stuff whenever I want to finish all the antidepressants, and we'll talk about them all as a bundle in regards to that. And then next, duloxetine. So it's actually a moderate 2D6 inhibitor, so may or may not, the ones that are, like I mentioned before, the strong ones are the ones I really worry about. Moderate, maybe. The milds, very rarely would I be concerned about a mild. But duloxetine's actually, of all of them, the only one that really does any kind of inhibition, right? I mean, like I said, desvenlafaxine's got a little bit of mild, but duloxetine's got some moderate 2D6 inhibition. So it's really the only one that does any kind of inhibition. And then it's metabolized by 1A2 and 2D6. So if you take it with an inhibitor of 1A2 or 2D6, its levels could be affected. All right. And then levomilnacipran, it's another one that doesn't have any inhibition of P450 enzymes. So venlafaxine and levomilnacipran, and then Vilazidone's the other one, I believe, that they basically don't affect anything at all. However, levomilnacipran is metabolized by 3A4, so a 3A4 inhibitor would affect levomilnacipran. And then levomilnacipran not recommended in end-stage renal disease, but many of them aren't. And like I said, we'll go over all that when we get done with all the antidepressants. And then the last point before we kind of wrap up the summary of the SNRIs is switching and discontinuing them. All right. I'm going to cover switching and discontinuing later when it comes to all meds, but I wanted to bring this up specifically with the SNRIs because they're a little bit different than switching and stopping the other antidepressants is fairly similar to the way you do it, but the SNRIs are more sensitive, right? As I mentioned, they all have short half-lives, and they can all get a pretty uncomfortable withdrawal syndrome, and venlafaxine being by far the worst. All right, so because of that, stopping them is a little bit more difficult, and switching in between them can be a little bit more challenging. And then also the fact that they have that NRI in there and other meds maybe don't have that, that's another thing you have to consider. So let's talk about all the different scenarios on switching and stopping. So first, switching to an SSNRI. So maybe they're taking an SSRI and we're going to an SNRI, right? So this is actually a pretty easy switch because they both block the reuptake of serotonin, and so we're just basically adding the NRI to it. So you could just switch kind of even dose for even dose. However, what you do have to consider is you're adding that NRI into there, and so you're thinking you don't want to go from max dose of SSRI to max dose of SNRI because although the serotonin effect should be pretty well tolerated, you're going from no NRI to like the max of the NRI. And so that's where you could get into a little bit of trouble there. And so I would want to ramp up the SNRI slowly. And so a cross taper might be appropriate when you're doing that. So cross taper is whenever you lower the med we're coming off of slowly as we're increasing the med that we're going on to. So say we're on, 200 of Zoloft and we're starting venlafaxine. So we go down to 150 of Zoloft and we go up to 37.5 or 75 milligrams of venlafaxine, and we have that dose. And then after a couple of weeks, we go down to 100 and up to, 112.5. And you kind of do it that way. So the other thing to consider here is if we're already on a higher dose of the SSRI, I'm not going to want to switch them to a low dose of SNRI because I already know that the high dose of the SSRI has been inadequate, right? So we're probably going to need the higher dose of the SNRI. And so I'm not going to take a month for each dose change as I'm going up. If I was starting them on the SSRI from scratch, I would probably go slower. But if they were on a lower dose SSRI, and they didn't tolerate higher doses, for whatever reason, they're already on a lower dose of the SSRI, then I would go slower. But if they were on a high dose of an SSRI, I'm already considering they're probably going to need a higher dose of the SNRI, and then, but we don't want to blast the NRI right away, and so I'll bring them up quicker. Like maybe I change the dose every 1 to 2 weeks instead of every 4 weeks, and I'd probably taper them down off the other one because I'm not, at the same time, I'm not going to want to go from like max SSRI to low dose SRI from the SNRI, right? Because their body's been used to this high dose of that, and then we're just going to like drop it down. So the cross taper was switching from an SSRI to an SNRI. Kind of the thought process here is, well, I want to maintain their high level of SSRI, so I need of SRI activity. So I'm going to want to keep that SSRI higher as I'm bringing up the SNRI, and then I want to keep the SRI activity at that same higher level, and I want to bring the NRI activity up slowly. And so that's how I'm going to do the cross taper there. And one thing to consider is, when we think about drug interactions, a lot of these meds are affected by 2D6, and then fluoxetine and paroxetine are 2D6 inhibitors. And so if you're doing a cross taper and the SSRI that they're on is fluoxetine or paroxetine, those are actually going to increase the levels of duloxetine and venlafaxine because they are metabolized by 2D6. And so that makes your taper a little bit more challenging, right? So if I was going from sertraline to duloxetine, I might do that taper a little bit differently since I'm not inhibiting the 2D6. But because fluoxetine and paroxetine do, I might lower them quicker. So you know, I ideally, I would not want those in their system at the same time because I don't want to be, then we're going to be blasting the SNRI when we're trying not to. So I mean, this probably sounds pretty complicated, and it is, and that's why this is a specialty in and of itself. It's for this type of nuance, and this is the type of nuance that family medicine is not aware of and doesn't have time to deal with. But maybe motivated family medicine folks that are out there listening to this podcast, hopefully you're at least aware, like, holy crap, maybe I do that and I didn't realize it, because I see, thank you family medicine for managing our patients at early stages. But yeah, I do see these kind of mistakes happen and patients come to me. I'm like, oh, well, that's because, they lowered this too fast, or they took the dose up too fast and they didn't realize that the CYP enzymes were affected and the nonlinear aspects of it and things like that. And I don't blame them at all because, I don't know about most of what they do. And so I can't expect them to have the expert knowledge on psychiatric medications that I have. But this is something to keep in mind. And then with fluoxetine, you also have the long half-life. And so, if I was switching from fluoxetine, I might consider, I might even consider stopping the fluoxetine because I know it's going to be in their system for like 1 to 4 weeks anyway. And it's going to be doing this inhibition of the duloxetine or venlafaxine that I'm starting them on anyway. And so if I start those at a low dose, but I stop the fluoxetine, it's going to be hanging around for a few weeks and it's going to be inhibiting the enzyme. Um, and I would just, I'd make the patients aware of this. And, if they're feeling uncomfortable, give the office a call and we'll troubleshoot it. But you remember when we were talking about SSRIs, this was a reason why I tend not to want to pick fluoxetine and paroxetine. And this is exactly, see, we've gotten into a mess with them right now, right? We've gone in saying, hey, great, we're going to use these, and they're not on any other meds that are affected by it. But now here we go, we're switching them to a med that is affected, and maybe we're needing to do a cross taper, and we've got the long half-life to contend with fluoxetine, and it becomes kind of complicated. All right, so the way you do the cross taper might differ depending on what SSRI you're switching them from. Okay, and like, even though fluoxetine and paroxetine both inhibit 2D6 strongly, paroxetine's got the short half-life, fluoxetine's got the long half-life. And so you might want to consider stopping the fluoxetine, letting it self-taper itself out. And the paroxetine, you might want to consider continuing it, but maybe cross-tapering it down quicker than you would if they were coming down off of a sertraline or an S-citalopram. All right. So, I mean, this is just, some of the nuance, and hopefully that's, some of the nuance that you're getting from the podcast that maybe you hadn't heard or read about before. All right. So that's switching from an SSRI to an SNRI. And I know I made it sound overly complicated, but, for most patients, you can just do it and they're not going to have any issues. But if they do, now you'll know why. And then you can explain it to them so they don't think that they're dying. Because patients always think, oh my gosh, am I having a heart attack? Am I having this? Am I going to die? And, it's good to know and what's happening. Oh, that's probably because of this effect. And I'm not concerned because, we know what's happening, and it's going to, and I can adjust it if we need to. All right. So what happens if we're switching from SNRI to another antidepressant? So now you're going from NRI action to no NRI action. And so, we don't want to come off that we don't want to go from like blasting NRI activity to not having it at all. Plus the withdrawal from going from full on NRI activity to like not any NRI activity is probably pretty unpleasant. All right. So that's why I would probably come down off of it slowly. But if we're switching over to fluoxetine, which I would consider not doing, because now we have the choice, right? We have the choice not to start fluoxetine. Do I want to give them a 2D6 inhibitor as we're tapering off of a med that's affected by 2D6? And remember, that's only duloxetine and venlafaxine. If they're on desvenlafaxine, we don't have that concern. And so you might be choosing your SSRI that you're going to based on avoiding one that interferes with the metabolism of the med that we're coming off. All right. I know that sounds really complicated, but that's why we get paid the big bucks, right? We get paid the big bucks because this is complicated. And we're there to help our patients navigate the pharmacokinetics and dynamics of all the meds and situations that they're in. All right. So keep that in mind when you're coming off. All right. We want to get that NRI down slowly. We don't want to just pull it completely off. All right. What happens if we're switching between SNRIs? So say maybe, we gave venlafaxine a go. They had some issues with it, but we still think an SNRI is the drug for them, and we're going to a duloxetine, right? In this case, a direct switch is probably going to be pretty good, right? We've got two meds that have pretty much the same function. Maybe they have a little bit different ratios, so maybe the dose of venlafaxine that they're on might affect our decision, but probably not. Say they're on 150 of venlafaxine, we're not getting much NRI activity. If we switch directly off that onto duloxetine, duloxetine is going to take over that SSRI activity and it's going to add NRI activity, right? No problem. So I really don't have a problem when we're going between SNRIs. Maybe if they're on the highest dose, you might want to consider a little bit of a cross taper, but probably not indicated. All right. And this last point, now those are the switchings, right? And we got the kind of the complicated issues with the switching. But what about stopping them? And this is the difficult thing, right? Because if you've ever taken a patient off of venlafaxine, you'll know what I'm talking about. It's pretty bad. I mentioned in a previous podcast that in the military, I wrote somebody what we call them chits. Basically a get out of work letter because you're sick, because the patient got so ill coming off of venlafaxine. And I had so many bad experiences with this. It's a reason why I just kind of skipped it. We have so many other meds to choose from. Do I really want to mess with the one that causes this horrible discontinuation syndrome? But say you've got somebody on it, and it can happen with any of the SNRIs. I'm just saying venlafaxine tends to be the worst, right? So if you're coming off and you're not replacing it with something else, you're going to want to go really slow, right? And with a lot of the SNRIs, there's not that, you're on 60 of duloxetine, that could be the starting dose. Like you can go down to 40, 20, stop. It's not a huge step, right? With desvenlafaxine, normal dose is 50, maybe 100 milligrams. Max dose is 400 for whatever reason, but like doses over 50 really haven't been shown to be that effective. So you really only got the one dose. Maybe you go down to 25. Pretty easy. But when you're talking about venlafaxine, we've got doses, starting at 37.5, going all the way up to 225, 300, and in some heroic situations, even as high as 600. And so it's going to take you forever to come off, and the slowest you can pull them off is 37.5 milligrams at a time. And that often is too much, right? And so there's a couple strategies that you could use. One is, we're taking them down 37.5 at a time. Maybe we're taking 1 to 2 weeks each time. If they're having a real rough go, I would hate to, take 2 months to get them off at a real rough go. It'd almost be better to go faster and get it over with. But, adding like a fluoxetine might be helpful. Okay. And the reason why, I know it's got the drug interaction, but fluoxetine's got that long half-life. And you don't have to use fluoxetine. You could use like maybe a Zoloft, and maybe the patient's like, but I wanted to stop meds. I don't want to change to one. And say, well, you're having a hard time getting off, and you're trying to get off, and you want to get off, and you can't get off, right? So to help you get off, I'm going to add an SSRI as we're titrating down. Once we're off the venlafaxine, then we can pull that SSRI away. All right, so that's one technique. If someone's having a real tough time coming off, you could add an SSRI, and fluoxetine's the one I've seen mentioned the most because of the long half-life. And you don't have to give a big dose, maybe a 10 to 20 milligrams dose, just to kind of ease that transition off, and then we'll stop the fluoxetine or whichever med after that. Now, the other technique, and this is what you could do is actually crush the pill, and you're going to want to use the immediate release. So in this case, we're on venlafaxine. We might switch them from XR. XR is once a day and IR is twice a day. We might be switching them to the IR dose so that they can crush the pill, and then they dissolve it in some sort of liquid, and then they pour it into 100 milliliters of fluid, and then pour off 1 milliliter at a time. Yeah, I mean, if that makes sense. So you're essentially going down by 1% each time you go down, and maybe you go down every few days, right? So you've crushed the entire pill. You've mixed it thoroughly into 100 milliliters of juice or water or whatever you want to mix it with, and then you pour off 1 milliliter. So now we have 99% of that drug left. You drink that. And then the next time you go down, you pour 2 milliliters off, and you're at 98. And maybe you could go a little faster. Maybe you go down to 95 and then 90. But this is a way to go slower. And once again, if you're using the IR, you've got to contend with the fact that this is a twice a day med, and they're going to have more withdrawal if they're only taking it once a day. And you can't do this with the XR because the beads, they can be sprinkled on something. So it's a little more challenging if you wanted to split the dose, because you can't really open those beads. You can just open it up and kind of sprinkle the certain amount you want, and throw the rest of them out. But if you want to do the crushing and putting in the fluid, you're going to have to use the IR for that. So that's the issue that you're going to have with doing that. But if you've got a patient that's having a real hard time and we really need to get them off, and we can use the SSRI on top, or we could do the little 100 milliliter flask, 1%, 5% drop at a time every 3 to 7 days or so. Maybe just let them kind of try to guide them through it. So let's do a summary of the SNRIs. So what are the advantages and disadvantages of these meds? And I'm kind of comparing them to the SSRIs because that's what we do. We've probably given them an SSRI, or we've considered an SSRI, and it hasn't worked, or we don't want to do it. And like, what are the advantages that these meds have? Okay. Well, one is that, I mean, when you look at duloxetine in particular and milnacipran, which is not an antidepressant, but they have these pain syndrome indications. And there's even though those are the meds that have the indications, there's no reason to think that, venlafaxine might not also be useful for pain. And in fact, I've seen venlafaxine listed in use with, I believe it was tension headaches. So, certain pain issues, these could be helpful. I've seen a patient that he had like neck pain after a car accident, and he was on duloxetine, found it helpful. Now, this is something that is frequently done, and when people go to pain clinics, they'll get put on an SNRI. And I think kind of the general thought here is, for real, honest to goodness pain, they don't work all that well. Okay. I think more of the effect is if there's more of a psychogenic component. And that's not to say that, it's all in your head kind of thing. Because the thing is, everything's all in your head. What controls your entire body? It's your brain. If your brain's not there, nothing else in your body does anything, right? So this stuff, when people say, "Oh, it's all in your head," or "Oh man, it's all in my head," it's like, yeah, it's all in your head. Everything's all in your head. Your head does everything. Your head tells you that you're in pain. Your head tells your heart to beat. Your brain controls your entire body. But at the same time, your mood is in there. It's mixed in there. Like, there's all these things with your mental health and your mood and your functioning and your anxiety and your concentration. All these symptoms, they're all in there, and they're all having an impact. And medical issues. Maybe someone's got some pain, but then they've got some mental health stuff on top of it. And if you take something to help with that, you're not going to have as much pain. So I think it's hard to know from patient to patient. There are definitely patients that they have like pain of an identifiable source. They take these meds and they have improvement through some sort of direct action on the pain nerves. Um, I think there's also that component of it just helps because their mental health is involved as well, right? And so you know you could consider an SSRI as well. But these meds actually have FDA approval, or at least duloxetine and milnacipran do, for pain conditions, and they've um, been proven to work more so than the SSRIs in those conditions. So I would certainly consider them, and I have definitely seen this work. It's not like oh great, this is awesome. I don't have to give someone an opiate. I'll give them this, and they'll be great. Maybe you'll get lucky. It's worth a go. If they've got some mental health stuff going on as well, some anxiety, depression, maybe this will also help. And there's also that massive placebo effect that I, went on and on about the last two episodes. That's in there. So I think the fact that they have these pain indications is definitely something to consider, but it's not like, oh wow, this is amazing, kind of thing. All right. And then, let's talk about that the norepinephrine reuptake inhibition. We're adding a function, and I kind of touched on what that's doing for us, but let's hit that a little bit harder. Um, Energy. And so like also what patients would you might consider, because there are patients where I'll start them on an SNRI before I've given them an SSRI. Oftentimes it's the patient that's failed the SSRI and we're like, okay, these are like SSRI plus they also do the NRI, so they do more, so maybe they'll be more likely to help. But there might be patients that have specific conditions where you're like, you know what, let's just go straight the SNRI, right? And so these are patients that are maybe lower energy, they have a lot of fatigue, the NRI activity may help with that. They may have poor concentration. They may even have ADHD or think they do, or you might be on the fence as to whether they do. And we might be able to have a little bit of improvement there, especially if it's not a full blown obvious case of ADHD. Then these may be enough to kind of give them a little bit more of that concentration. And then that NRI activity also helps with depression and anxiety. So it's like the serotonin helps with depression and anxiety, the NRI helps a little bit more with it, but it also can help you get going and moving and be motivated and concentrate better. So uh, you're adding some more stuff there. And as I said, with the pain stuff, if I've got a patient that's already got some chronic pain stuff going on, and I was going to start an SSRI, maybe I go with the SNRI first, because like, well, maybe this will also help with this, and two birds with one stone kind of deal. Other advantages. So, as I mentioned, a lot less drug-drug interactions than the SSRIs. So that's a benefit. Um, and then if they failed an SSRI, they may not fail one of these. So these may work a little bit better. And when we look at effect sizes, and I'm going to have a summary of that once we get through with all the meds too, the effect sizes of the SNRIs are slightly higher than the SSRIs. So they do work a little bit better. And so many of you may be asking yourselves, well, if they work a little bit better and they treat some symptoms that the SSRIs don't treat, and they don't have the drug-drug interactions, why don't we always go with them first? Right? Like, why even go through the SSRIs? They do what the SSRIs do, and they do other stuff. This is like better, right? I should always do this. Well, let's look at some of the disadvantages and see why we might not do that, right? So, I mean, one disadvantage is they have all the same serotonergic adverse effects as the SSRIs, right? So they still have all the things I talked about negatively about the SSRIs. They have that stuff too. In addition to that, they've got that blood pressure, cardiac risk, heart rate increase, so that's not great. And that would be the big reason why I wouldn't just go straight to an SNRI for all patients because, I'm already giving them these serotonergic risks. Do I want to give them the norepinephrine risks as well? Well, maybe, but let's first find out if the SSRI works. Because if the SSRI works, why give them the norepinephrine risks on top of that? Why introduce that, right? We only want to do that if there's a reason to. And the reason is they tried an SSRI, it didn't work. Or they've got the pain syndrome, or maybe we've got some drug interaction things that we're concerned about, or maybe they've got some extra some ADHD like symptoms and they're complaining about that and be like, well, we could give you this and it could help with both, right? So there, if we you really you need to have a reason to use an SNRI first. You just don't use it straight off the bat because you are introducing these additional adverse effects from that norepinephrine, all right, which are mostly cardiac. And we don't want to affect cardiac. So this is something where you know I know vital signs are typically checked. I don't know if it's like everywhere, but if you're putting someone on a norepinephrine medication, we definitely want to make sure we're checking vital signs before and after because we want to know, did we make it worse? Because I mean, if they were high before and they're high after and it didn't change at all, well, then it wasn't this, right? But if they were low before and then it goes up, I don't want to start a blood pressure medication on them just because I started them on an SNRI, right? All right, and let's continue with the disadvantages. The short half-lives, right? So the SSRIs, for the most part, don't have that issue. And it's a really nasty issue because it causes you can get withdrawal. Remember how I said, if you take paroxetine, you kind of have to take it at the same time every day? Well, with venlafaxine, I get patients where they're like, man, if I'm 5 minutes late, I notice the effects. Or even like I notice it happening right as I'm about approaching the exact time to take the meds. So like if they don't have their meds on them at all times, I mean, and some people are more sensitive to this than others, right? And so if that could be a huge issue. I talked about how nasty it is to get off of venlafaxine. It can be nasty to be on it because guess what? Patients miss meds sometimes. What if they miss a day? Then they feel like garbage, right? If you miss a day on a sertraline or a fluoxetine, you're not really going to notice the difference. You may not get all the benefit, but you're not really going to get that withdrawal within a day. But with these, you will, especially venlafaxine, right? So they accidentally miss a dose or they left their pills at home and they're out and they can't get to them. And now they're having all this serotonin withdrawal syndrome type of stuff going on and they feel like garbage. And it's like, and they're just like, I can't remember to take it every single freaking day at the same time. I just can't. And so if you can't, if you have that withdrawal effect and you just can't be able to commit to taking it extremely consistently, then this is probably not the medication for you. And I've had many a patient that have been on these and have had that effect that I have taken off of them purely based on the fact that their compliance wasn't perfect. And I don't expect perfect compliance. It's difficult, right? And like I said, not all patients are going to get this. Some patients are going to have no withdrawal syndromes, right? But if you are a patient where that happens and you're not as compliant as you need to be to prevent it and you're not able to like train yourself to get there, then this is probably not the medication for you. You've got a hectic life, I mean, that's why I recommend, if you've got a bag or a purse or something, maybe have a separate pill bottle that has a couple pills in it that you carry all the time and have your main bottle at home that you take in your routine, but then have your bottle with a couple in it that goes with you everywhere. And that way, if you ever get into this mess where it's like, oh my gosh, I don't have my meds. Oh wait, I do. I keep them in my car. I keep them in my purse. I keep them in a bag that I bring with me everywhere. And so that could, we can do some behavioral modifications to solve this problem. All right. But not everyone can do that. And so that's so the short half-life and the bad withdrawal is a huge consideration on disadvantages. All right. I've got a couple more. So another disadvantage is they don't have the same effect of higher doses helping with treatment-resistant anxiety as SSRIs do. I'm not sure why this is, but oftentimes with like OCD or like severe anxiety, doing super therapeutic, so like above the max dose range of SSRIs, you're getting added benefit. But with these, not really. You're not getting venlafaxine. You can get more benefit with relatively higher doses, but with the other ones, like duloxetine's max dose is 120, but generally 60 is about as high as going to help. Desvenlafaxine, you can go up to 400, but 100, 50, and certainly no more than 100 is typically, you're not really getting any benefit beyond that. So that could be a good point in that, we don't have to do a lot of titration, but it could be a bad point in that, if it didn't work, if we up it, it's really not going to do a whole lot better. But once again, there are patients for which I had on 90 milligrams of duloxetine or 120 milligrams, and they did better than 60, right? We're just talking about averages here, right? We're just talking about in general. Generally, the higher doses don't add much benefit, but for some patients, they might. And it might be, increased placebo. Taking a bigger pill or a higher dose, it could just confer a better placebo effect. And then last one is they all have a dose adjustment recommendations for renal impairment. So if you have renal impairment, these medications can be tricky. And like I said, we're going to go into that later. I'll go into the details on that, and we'll talk about what meds might be best in patients with renal issues and what meds might be best in some people with hepatic impairment, and which ones are the best, which ones are the worst, and which ones you can kind of walk the line on. And I'll have we'll do a whole deal on that. But just, to kind of round out the disadvantages, renal impairment affects all these. And remember, duloxetine, hepatic impairment, big no-no with these. So I think that wraps up this episode pretty good. That's our SNRI overview. And in the next episode, I'll go through there's 5, right? The 5 SNRIs. We'll talk about each of them individually. We've already kind of glossed over some of the different effects, but we'll go into detail and we'll talk about advantages and disadvantages of each one, why you might pick one over the other in different situations. So, I want to thank you for tuning in. Like, follow, subscribe, tell your friends, and I will see you next time.